Bismillah ar-Rahman ar-Rahim. The lecture today will be about eyelid malposition and facial palsy. The lecture is so big to go and cover everything. It's 1 hour is not enough. So what I'm gonna do is gonna just touch on some clinical tips that I think it'd be useful to keep in mind when you evaluate a patient with eyelid malposition or handle a patient with facial palsy. We're not gonna go in details, but otherwise we'll not be able to cover important stuff. We're talking about entropion, ectropion. There will be a separate lecture about ptosis and lid retraction, which will be part of thyroid eye disease, the lid retraction, malposition. As you know, entropion can be different types. And we mean by entropion is the eyelid margins turning toward the eye, which can be cicatricial, which is the common thing we see here as sequelae of trachoma, which used to be very common in our area. Now we see only the sequelae of trachoma, and the most common one we see in oculoplasty is the entropion in the upper eyelid. It's less frequent to cause entropion in the lower lid. When you see entropion secretration in the lower lid, you need to think about something else, like secretion pemphigoid or Stephen Johnson or other causes of secretion changes in the conjunctiva. Involutional type, which is another common type of entropion, and this is commonly or almost always in the lower lid. It doesn't count to say involution entropion in the upper lid. It doesn't work. Okay. What involutional changes you will see in the upper eyelid? Ptosis. Yeah, dermatochalasis, fascination, but we don't see ectropion as involutional changes. Congenital, it happens, but we need to differentiate between epiblepharon and entropion. The main thing to help you in differentiating is, without touching the eyelid, to look at the lid margin. If the lid margin is normal, this is epinephrine. The lid margin is inverted inside, this is if the lid margin is okay, this is epinephrine. If the lid margin is inverted inside, this is congenital entropion. Especially in some races, epinephrine is way more common, especially in Asian, and we see it here frequently. And the good thing about epinephrine, it improves with time, so we don't need to rush for surgery unless there is corneal ulceration or compromised ocular surface function, that we need to intervene surgically. Spastic or acute spastic is because of spasm in the orbicularis, so we need to see the cause for the spasm. If we are able to treat it, that will be good. If not, we can treat it with botulinum toxin. So secretion entropion, again, it's the most common we see as a result of trachoma. What we see, and clinically we see the entropion, as we mentioned, the lid margin is turning toward the eye. Inability to correct the ectropion by down traction of the lid, which differentiated from the involution that we're going to touch on in a minute. And when you avert the lid, you see the scarring in the conjunctiva, either in the upper eyelid or in the lower eyelid. As a sequelae of the entropion, we'll see corneal irritation as SPKs, or sometimes you can see corneal scarring from the chronicity of the entropion. Do we need to do a lab test? If it's trachoma straightforward, you don't need to, because it's a sequelae, especially if you see other sign of trachoma. But if you don't see the typical finding of trachoma, you need to ask for lab test, and sometimes maybe need to do biopsy to prove what type of cicatricial changes happening in the conjunctiva. If a patient is known to have Stephen Johnson syndrome and you know the cause, that would be good. If you don't know the cause, maybe you need somebody to help you knowing the cause for Stephen Johnson syndrome. One important thing that it's really I focus on in the clinic when we have people with us in the clinic, to look at the meibomian gland orifices. If a patient have entropion, cicatricial entropion, the meibomian gland orifice will not be in their normal position. You will see them like this. And this is one of the things that differentiate cicatricial entropion from other type of entropion. As you can see here, you see the meibomian gland orifices here is bold. The only thing that causes entropion with changing the meibomian gland position is cicatricial changes, okay? Other thing with the cicatricial entropion, you see the entropion in one part of the eyelid more than the upper part of the eyelid, other part of the eyelid. Because cicatricial change is not typically uniform along the eyelid. So if you see entropion in medial part of the eyelid more than the lateral, or lateral more than the medial, you think about cicatricial changes. Because involutional changes, typically you see it uniform along the eyelid, because the conjunctiva should be normal in patients with involutional entropion, okay? How we treat entropion? We treat it with lubrication and bandage contact lens if the patient is bridged for surgery. The definitive treatment is surgery for it, and it depends on what the entropion composed of, or what's the cause of the entropion, and also is it the upper eyelid or the lower eyelid. And there are different options that we can treat cicatricial entropion with. It can be anterior lamellar repositioning, lid margin reposition, tarsal fracture. Sometimes maybe you need to use a mucous membrane graft or combination of above procedures. This is what we mean by the anterior lamellar recession. So you separate the anterior lamella from the posterior lamella, then you advance the posterior lamella down. So there will be gap between, and this gap will be filled by granulation, or you can put a mucous membrane on it, okay? This is what we call anterior lamellar reposition or recession. This is what we call lid margin rotation. You do cut in the tarsus, and that cut typically we made it at the Arnold's line, especially if we are dealing with a trachoma. Then after that you use a suture to rotate, as you can see from here, and you rotate the lid margin. You can do it from posterior approach, or you can do it also with anterior approach. What typically I do both. Anterior from the lid decrease to free the tarsus from the anterior lamella, and I make the cut through the Arnold's line, then I do the rotation suture. I found it to be more predictive, and longevity is better. What about involutional entropion? As we mentioned before, it affects the lower eyelid. We don't see it in the upper eyelid. Why it happens? Because of the laxity, and that can be either horizontal laxity or vertical laxity. What we mean by the horizontal laxity, that's meaning laxity in the medial canthal tendon or lateral canthal tendon. What we mean by vertical laxity? Anybody?
Tarsus?
Huh?
Tarsus?
No. So when you say vertical laxity, horizontal laxity, we're talking about medial and lateral canthal tendon. What about vertical laxity? What do we mean by laxity where? Because this is going to be part of the management. Huh? Tarsus? No. When you say vertical laxity, we mean laxity or dehiscent in where?
The face of
Huh?
The basal
Yeah, lower lid retractors, which is the capsulobular fascia, okay? That's why it's part of the management, as we're gonna discuss in a minute, okay? Actually, it's mentioned down here. And the interesting thing is the mechanism or the laxity. We can see it in the entropion and ectropion, the lower lid. Why some people they developed entropion and some people they developed ectropion? I think it has to do with the prominence of the eye. If the eye is prominent, the eye will be more toward ectropion. If the eye is not prominent or enophthalmic, the lid will be having more tendency toward entropion. دكتورة روان تسلم عليكم وتقول كمان the tarsus it has a role. So there is one study published that's showing that the tarsal height, if the height of the tarsus is more than normal, the patient will tend up to have ectropion. If the tarsal height less than normal, they tend to have entropion. Okay. Otherwise, the laxity, horizontal or vertical laxity, you find it in both. Okay. Other people they add to it orbicularis overriding and other things as a causes for the involution entropion. What you see clinically for these patients, we see the lateral canthal laxity, medial canthal laxity, and also we see changes because of the ocular surface rotation, as we mentioned before, corneal exposure, and also reflex tearing. How we test for the laxity? We test by the distraction test for medial or lateral canthal tendon, and also the eyelid laxity, which we're going to show a picture on it. Other thing, the snapback test, which is the more frequent I see in the clinic, I do in the clinic because it's easier to do and you don't need to measure. So what you do, you distract the eyelid. If it goes immediately, that means the laxity, no laxity. If it goes with blinking, that means there is moderate laxity. But if it doesn't go even with the blinking, that is very severe laxity. And this is what we call by distraction. You see how much the eye is distracted from the eyeball, and you measure that. This is a picture to highlight what I mentioned before, that entropy is uniform in evolutional ptosis. You can see the lashes here. You see almost the entropy is uniformly equal in medial and central and lateral. In cicatricial entropy, you don't see it as uniform as this. So this is one of the things that help you differentiate between the two. So the treatment again for entropion or ectropion or both is the surgery. No medical treatment apart from Botox for spastic entropion. So what we do to treat entropion, as we mentioned before, the reason for entropion is the medial and lateral lid laxity and horizontal or vertical lid laxity. So if it's a mild to moderate one, we can do horizontal laxity management, which can be in form of canthoplasty or lateral tarsus strip. If it's a severe one, we need to do lower lid retractor reinsertion to fix the vertical laxity. And this is what we, just quick description from Dr. Neeraj book. So we do lateral tarsus strip. This is just local anesthesia. We do canthotomy, lateral canthotomy, and cantholysis to mobilize the lid. Then after that, we create the lateral tarsus strip. Then after that, we shorten the tarsus, so we'll make the eyelid tighter. Then we fix it to the prominent lateral bone, the outer tubercle here, to manage the lateral tendon laxity. And the close. If the patient has severe one or there is significant vertical laxity, we need to do lower lid retractor reinsertion to strengthen the lower lid retractors. You can do it either through transconjunctival approach or subciliary approach through the skin. And here that's just a subciliary. And this is the elevator. This is the lower lid retractor. We just reinforce them. We don't need to dissect and attach them again. Just more suture for 2 or 3 suture for plication. Usually it does the job. And here just to show you the picture from lateral, you see the lower lid retractor are reinforced or plicated for managing the vertical laxity. We talk about the acute spastic, and this is because of irritation in orbicularis muscle and can be related to ocular surface irritation or can be happening without irritation. The most important thing is to recognize the cause and treat the cause, and most of the time when you treat the ocular irritation, the spastic improve. But if it doesn't improve, you need to treat it either with a botulinum toxin. Some people, the chronic spastic changes, they will end up with laxity in the eyelid. So if there is significant laxity, you need to do lateral tarsus strip as part of the management of the laxity that happens secondary to the spastic entropy. And this is just summarizing what we just mentioned. Ectropion is the opposite, is the lid margin is turning away from the eye. And evolutional type is the most common, especially in the lower eyelid. Congenital it happens, but it's really rare. Paralytic because of facial nerve palsy is a frequent one. And cicatricial because of the skin changes either from previous surgery or from burn or other causes that causes short lamella, also part of the management. Evolution entropy, as we mentioned, there is horizontal or vertical laxity that leads into this eyelid malposition. And we mention again the patient with a prominent globe, they have tendency to develop ectropion, while in ophthalmic globe they tend to have entropion. So in the clinical feature, you see the laxity, horizontal and vertical laxity, as we just discussed before, and the ocular irritation because of the eyelid malposition. Distraction test again, and also the management of lid measurement of the lid laxity, how lax or the distance between the globe and the eyelid also helps in making the diagnosis. And snapback test, again, it helps in making that diagnosis. Surgical, medical treatment for lubrication and recurrent surface management, also part of the management. The surgical management is the definitive, and it's similar to what we just discussed about entropion. So we do lateral tarsal strip and lower lid retraction depending on the severity of the and degree of the laxity. Again, if it's mild entropion, you do lateral tarsal strip. If it's severe one, you need to add to it lower lid retractory insertion. Cicatricial ectropion because of the scarring in the anterior lamella, and as a result of chronic scarring, there will be sometimes keratinization of the because of the chronic cicatricial ectropion. In some patients, they will do keratinization of the conjunctiva because of the chronic dryness in the conjunctiva. Some keratinization will happen, and this is, you see it in patient that's been there for a good number of years. Again, with the cicatricial ectropion, you see sign of exposure, and one of the things that to help you that there's changes in the anterior lamella, when you ask the patient to open the mouth, the ectropion become worse because of the short in the anterior lamella. How we treat the cicatricial ectropion, it depends on the assessment of the shortening or the deficiency in the anterior lamella, and if there is a laxity in the eyelid, either medial or lateral or vertical. How you treat it? You can use skin graft to elongate the anterior lamella, and sometimes we need to add to it lateral tarsal strip if there is horizontal laxity. Skin graft, you can use split thickness or full thickness. I prefer full thickness because it gives better lid correction position, and also the skin match will be better. This is unusual, just I want to share it with you. This is a patient with ichthyosis, and you know ichthyosis is the skin is affected all over the body. So if you take a skin from behind the ear, the skin is also affected. So in this patient, I elected to use a mucous membrane because the mucous membrane is not affected by ichthyosis. So we did correction of the lower eyelid and upper eyelid with mucous membrane, and this is her appearance. You can see that just this is recent, like 1 month after the surgery, still the mucous membrane not keratinized enough. And before doing the upper eyelid, you can see here before, and you can see that after here, the lower eyelid. And this is before the surgery in the upper eyelid. You can see she cannot close her eyes, and this is after putting a mucous membrane, she can close the eye completely. This is one of the, it's not the classic treatment, but I thought just to mention that it's one of the options you can use and utilize. Any questions so far? في أي إضافة دكتور محمد؟ تبس شيء في الزملاء؟
في الاكثيوسز some of the patients we refer to dermatology for starting oral treatment to reduce the can improve the skin texture, and that may help to consider skin graft in some patients. And in some patients, if the ectropion is mild, some of the recent literature can use filler in the lower lid margin just to lift it or keep make it a little bit of toward the globe. So these are the tips that I may add.
Yeah, but just I want to confirm is still the skin graft is the standard treatment for ichthyosis, okay? Just to show you something that it can be utilized. So if you ask an exam or anywhere, what's the treatment is? Skin graft, okay. Then this is the classic. فما أبغى تطلع بحاجة بيقول لك ليش سويتها. Just to show you experience, my experience with mucous membrane.
بالنسبة للسكين matching يعني what is the best place to take from?
طبعا the best place is the eyelid. For example, if a patient has cicatricial change in the lower eyelid and there is excess skin in the upper eyelid, take from there down or the opposite. So the best match is the eyelid. The second one I use is the area that behind the ear. It gives really thin skin. You can use supracular And then after that, you can go on. Okay, so okay, now we talk a little bit about facial palsy. Facial palsy is really important nerve, or facial nerve is an important nerve for the whole face. So the patient with the facial palsy, I think they deserve really what you call multidisciplinary approach. You cannot treat it as ophthalmologist alone. Facial plastic, they can't treat it alone. They need really even psychiatric support, because it really changed the patient really life dramatically. So they need really a special treatment and special support. Facial nerve is a big nerve and contains really around 10,000 nerve fibers. That means because of the huge function that nerve serves. And there is nerve for the expression, and also nerve for secreting the tears and the saliva. So it has different function, plus sensory innervation for the tongue. So it has multiple function. The facial nerve goes really, it takes a long path, and at any part of this path can be injured. So we can have injury intracranially, extracranially, in the face, and even along the auditory canal, the facial nerve canal in the auditory canal. So it has really different, let's say, insulting factor. It depends which location it happens. So your patient may have a tumor that causes either intracranial but lower motor neuron lesion, or can happen in the the brainstem and cause the supranuclear problem, which we don't see in ophthalmology. What we see in ophthalmology is the lower motor neuron lesion. Middle ear is another part of the or other place for other causes like middle ear infection, costoneuroma, other causes. When the facial nerve leaves the canal and go in the parotid gland, there is another set of problem that can happen in that location. And sometimes the patient have only one of the branches that get affected because of trauma, or some infection happened, like hepatic, that cause only one branch of these to be affected. So it depends on the location. The manifestation will be the guide to locate the pathology. One of the important things to locate the pathology, also the tearing. If the patient is having tearing, that means the injury happened above this location, because the nerve leaves at this location here. If the patient have, for example, a caustic problem, that means they have the injury with the tear, with the lacrimal gland is affected. If they don't have a problem with the caustic, that means the most likely the injury is below and the tears is preserved. When you see a textbook, you see this multiple branches of facial nerve. They look beautiful in drawing, but in the reality is not as delineated as this. So there are multiple branches, can be more than one in serving one location. So this is mainly of like academic and simplifying the anatomy of the facial nerve. So we have the temporal branch, zygomatic, mandibular, and these can be branched to smaller branches. We mentioned that we see in ophthalmology is a lower motor neuron lesion, and can be either infectious, inflammatory, traumatic, iatrogenic, congenital, idiopathic, or neoplastic. Infectious, the common infectious problem we see is the middle ear, and some people propose that Bell's palsy is a form of infectious or semi-infectious because of relation to herpetic infection. Inflammatory, like sarcoidosis, can affect the facial nerve. Trauma, it's clear, is a common cause. Iatrogenic, because of injury either in the middle ear or in the parotid gland surgery. Congenital, which is another frequent cause we see. Idiopathic, which be referred to Bell's palsy. And neoplastic, anywhere along the course of the nerve. What are the ophthalmic presentation of facial nerve palsy? Eyebrow ptosis, this is an adult. Lagophthalmos, ectropion, upper eyelid retraction is another clinical manifestation, exposure keratopathy, and epiphora. If it happens because of reflex tearing, also compromised blinking is another cause for the epiphora along with ectropia. So this patient with typical facial palsy, you can see the ectropion and you can see the lack of thalamus, plus you can see the changes down in the face. I mean, you didn't see much brow ptosis because of the involutional changes, the patient has bilateral brow ptosis. One of the important things is, when do you image patient with facial palsy? This is one of the things that, do we need to image all of them? Depends on the cause, we can image. No clear cut answer, but what we really do is imaging with a slow onset of symptoms. Typically, Bell's palsy comes sudden, but if it's the symptoms building up gradually, you need to think about something pressing or some tumor that's growing. So slow onset of symptoms is one of the indication. If the function is not returning, because if it's Bell's palsy, you expect it to return within a few weeks. But if the function is not returning back, especially after 6 weeks, you need to worry about the cause. Other thing is recurrent, especially if it's bilateral. You need to image because not typical for Bell's palsy to recur. If it's recur, you need to think about something else. So mainly slow onset of symptoms, no return of function, and recurrent. Some people, if it's bilateral, they will image too. And this is one of the things you can consider. Lab tests, it depends on your clinical investigation or clinical data or clinical feature. If a patient, for example, you expect them to have sarcoidosis, you need to investigate. If the patient, they have, for example, parotid gland swelling, you need to investigate. So it depends on the clinical finding, the lab test will be directed. So how you manage patient with facial palsy? As we mentioned before, that it's good to involve other team to manage the patient and helping them to recover from this major facial insult. And the other part of management, it depends on you expect the facial nerve to improve or not. If you expect the patient to be improving and you expect that it's most likely a Bell's palsy, you need to use a temporary measure, like using topical lubrication with ointment and gel. Sometimes you can close the eye at night with taping. Some people use glue or botulinum toxin to induce ptosis to help decreasing the exposure keratopathy. This is as a temporary measure. Temporal tarsorrhaphy is another option that you can use in selected patients, especially if there is severe corneal ulceration or exposure. So if it's Bell's palsy or ischemic, most of the time it improves. And this is our patient that showed you picture before. And so he improved within 6 weeks. If recovery not expected, or the patient, you waited for them and they didn't recover, you need to use a permanent measure to manage the ophthalmic manifestation. And the surgery you need to choose is depends on the patient finding, because patient, they present with different findings. For example, for correcting a lack of thalamus, you can use upper lid weight and upper eyelid recession to lower the eyelid. A lower eyelid drop and ectropion also you need to manage with the lateral tarsus strap. Sometimes you do mid-face lift to manage the lower lid retraction and the dropping of the lower eyelid. Brow ptosis and blepharoplasty is another option for surgical management. This is just a video to show you why we use a gold weight. This is a patient. You see the blinking in the right eye? I'm sorry, the left eye. And you see why we use a gold weight, or the weight in the upper eye. You see the improvement in the upper lid blinking. So the gold weight, or the weight, either gold or platinum, the main aim of it is to improve the blinking. And this is the dynamic way of improvement. Some people use spring, which is falling out of flavor because of complication. You may need about it, but only very few people are doing it now because of long-term complication. This gold weight, you fix it in the top of the tarsus. The location varies from one surgeon to another. I like to put it in the upper third of the tarsus or upper half of the tarsus. Other options to use platinum is another also option that can be utilized. We mentioned about the lower eyelid malposition and facial mid-face descent. Also, that can be addressed, especially in elderly, because they have a huge laxity in the face. With the facial palsy, that will be becoming really pronounced compared to young adult. And that can be managed with lateral tarsal strap, mid-face lift, and also sometimes you need to use spacer for the upper eyelid to support the upper eyelid, the spacer to the lower eyelid, to support the lower eyelid to get back to acceptable position. Other options, especially for if you cannot, this is one of the things that I want to avoid as much as possible, tarsorrhaphy. Permanent tarsorrhaphy, most of the patients, they don't like it, unless we have to do it. The lateral tarsorrhaphy is one option. The other option can be utilized is this is just to explain separating the anterior lamella from posterior lamella. Then after that you need to deepithelize the posterior lamella, so you will help the posterior lamella to attach to each other, because if there is epithelium they will not attach to each other. Then after that you suture them, the posterior lamella together and the anterior lamella together. Typically if you want to do lateral tarsal strap, lateral tarsorrhaphy, you need to go up to the limbus here. Otherwise it's not effective, it will not help the patient. If you are doing it for helping exposure keratopathy, you need to reach up to the lateral limbus. If you're beyond that, it will not help much. That's why what I do more is the paracentral tarsorrhaphy, which I do more frequent, because what I need to close only a small part here. And this part also, the medial part, the patient will not have very severe compromised visual field, because the nose compromising the visual field medially. But if you close the lateral, the patient will miss the lateral visual field. So I like more the paracentral, and you can do also medial, but I don't do medial a lot because the canaliculi are there. So I do paracentral, just lateral to the puncti, upper and lower puncti, and to help managing the exposure, because most of the problem in the eyelid exposure coming in the central part of the eyelid, and this one addressing it in a better way than lateral tarsorrhaphy. What about epiphora? Epiphora can be a result of reflex tearing from dry eye, paralytic ectropin as we mentioned, or hypersecretion or aberrant innervation from the lacrimal gland, or we call it crocodile tears, especially in patients when they recover the facial nerve function. They will have tearing whenever they eat because of the crocodile or aberrant regeneration of the lacrimal gland. So for the tear management, it depends. If there is exposure, you need to treat the exposure. If there is laxity, you need to treat the laxity. And if there is hypersecretion or aberrant innervation, you can use botulinum toxin for the lacrimal gland to help decreasing the amount of tearing, especially when during eating. This is a small thing that I want to touch because I have some interest on. It's a pediatric facial palsy. Pediatric facial palsy, they don't present exactly like adult, because the facial connective tissue and the tendons in the adult, not like in children. Children, they are more, let's say, the tendon are tight, and the facial connective tissue is really tight. So you don't see the typical manifestation as you see in adult. One of the things that we see more in children is entropion in the lower eyelid, and we see it more common than ectropion in the lower eyelid. And we are going to publish series soon about entropion is like double the amount. The entropion is doubling the amount of ectropion in the lower eyelid in children with a facial palsy. And this is just pre-op and post-op. And this is a patient with mild entropion. Other thing, you don't see the brow ptosis like you see in adult. For example, this patient, he's still in the 80s, but you didn't see brow ptosis. But when you ask him to raise his brow, you see how much compromised function, but you don't see much of brow ptosis. So if you don't ask them, maybe you will miss this sign. So you don't see pronounced brow ptosis as you see in adult. Other thing you observe in patients with facial palsy, and this is one of the things that people don't pay attention to, is lower lid retraction. You can see the lower lid here, and you can see it in the other eye because of facial palsy. So sometimes lower lid retraction, you need to ask about facial palsy or previous facial palsy to know is it the cause or not. So lower lid retraction is another frequent episode. You see it in the patient with facial palsy without clear ectropion or other eyelid malposition. This is patient again with lower lid retraction. And here we mentioned that the manifestation in children is not like in the adults because of the strong connective tissue and facial tendon. One of the things that we see about after facial palsy is abrupt regeneration. And one of the really frequent one we see is post-paralytic spasm. And the patient, they recover and with the spasm. Sometimes the spasm happen with other movement. We mentioned about tearing with eating. And this patient also, you see his face, when he's moving his mouth, the eye closes. This is another abrupt regeneration. So this is one of the things that can happen with the recovery of the facial nerves that we need to pay attention. We need to pay attention to, and we call it synchesis. This patient, she had a history of facial palsy before in the left side, and you see her face. You see the twitching. This is because of previous facial palsy. You can see the tightness in the mouth here because of the nerve recovers, but recovers more than what we want. So she developed post-paralytic spasm. How we treat this one? We treat it with botulinum toxin to relax it and gives the release for 3 to 6 months. Typically, when you use the botulinum toxin for post-paralytic spasm, we use a smaller dose because the muscle is hypersensitive to the botulinum toxin. Not like essential peripheral spasm. The nerve, the muscle sensitivity is more in post-paralytic spasm to the bottom. So we need, typically I use half the dose when I treat patient with post-paralytic spasm. And we treat in the typical manner for the essential peripheral spasm.